Dr. Eliott here. I'm honored to introduce our guest speaker, Dr. Dean Eliott. Dr. Eliott trained at Duke, Vanderbilt, and Cornell University, as well as the Wilmer Eye Institute at the Johns Hopkins Hospital. He has served on the faculty of Duke, Wayne State, University of Southern California, and the Harvard Medical School. He has dedicated his research to new approaches to combat retinal disorders, particularly macular degeneration, diabetic retinopathy, and complex vitreoretinal surgical disorders. He has been a consultant to most of the major ophthalmic drug and device manufacturers and has been involved in numerous clinical research studies. He has received 19 awards and prizes. He has trained 59 retina specialists. He has given over 175 lectures in the US, 65 internationally, and has published over 60 peer-reviewed articles, as well as 16 books or book chapters. So it's with great pleasure for me to introduce Dr. Eliott, who's going to share with us what he has learned in his work on the transplantation of stem cells for the treatment of dry age-related macular degeneration. And I want to say that the first person you're going to hear about here is one that has come from Fort Myers and went up to Boston to have this done. And so some of what you're going to hear about is going to be work that was done in one of the patients that's from our community. So without further ado, here's Dr. Eliott.
Alex and I were fellows together about 20 years ago, and he always did what was in his patient's best interest. He really took great care of his patients, and it's really a pleasure to come down here and see how well Alex has done. He's assembled a great group here, and I'm excited to be here. I'd also like to thank Tim and the Foundation Fighting Blindness. They really do wonderful things. I can lobby for them since I have nothing to do with them, but if you're thinking about making a donation, it's a great place to put your money. They really do fantastic things and really help society through their funding efforts. So Tim, thanks a lot. It's great to have you guys support this. So we'll be talking about stem cells for dry macular degeneration. And I want to separate a little bit of the hype from reality, because stem cells get a lot of attention in the news, but to date, only less than 20 patients have actually had stem cells implanted into their eye. And although this is a great treatment, I think in the future, it's important to realize that right now we're not quite ready for prime time. So I'll talk about some of the conditions that it's used for. I have no financial interest in this topic. So as you saw, the eye is like a camera. And the retina is the orange structure here, which is analogous to the film in the camera. And the light rays get focused through the cornea and the lens. And the beam of light gets focused on the retina, which then travels, the message travels through the optic nerve to the brain, and your brain interprets that as vision. And you see on the right, that's a picture of a retina flattened out. It looks like an orange. But that's basically the central part of the retina. You'll see some other pictures today, just so you get some orientation. You can see the optic nerve. The macula is the central part of the retina, which is important for fine vision. You see some of the arteries and veins that nourish the retina. So that's the basic anatomy, which most of you are probably familiar with. So how many people in the audience have some sort of eye disease, either cataracts or have had cataract surgery, or glaucoma, or macular degeneration? Raise your hands. Those are huge numbers, okay? And how many of you have macular degeneration? Wow. And how many don't have any eye disease, but you're here because a loved one has eye disease, or you just want to learn some more? Okay? So we'll try to fine-tune this discussion to the audience that we have. So then most of you are familiar with dry macular degeneration. Here's a patient with drusen, or little yellow deposits, which should not be there. And this patient actually has either normal vision or very close to normal vision. So this is a patient with dry that is not a candidate for stem cell study because the vision is pretty good. Now here's a patient with a different type of dry. This is the atrophy. That big circle in the middle here, this area here, whereas these are some drusen out here. So this patient has decreased vision because the area of atrophy, that light area in the middle, is basically a blind spot. That's where the retinal pigment epithelium, as well as the rods and cones, are not present anymore, are not functioning. So here's a patient that might be a candidate for a stem cell implant, also with dry. Here's another dry that's even more serious. The area of atrophy in the center is even larger, and this patient has a big blind spot. Here's another patient with dry. Sometimes the findings can be pretty subtle. There's actually a few little areas of atrophy. This little yellow here, and the yellow here, but this patient has normal vision. Because here's the very center of the retina, this darker area, which is the way it's supposed to look. This patient has almost 20/20 vision and is not a candidate for stem cells therapy, even though they have some atrophy or dry macular degeneration. And here's another patient that has some atrophy right here and lots of drusen scattered around. And this patient's not a candidate either because the vision is pretty good. So here's a patient. This is the actual patient we did the stem cell surgery on. Here's a patient with large area of atrophy in the middle, as you see on the photograph. And on the right, you see a visual field test. Those little lines are like a topographic map. And in the center, it's dark. That's the blue area. That's the visual field defect. So if this person was looking out at the audience, they would have a big blind spot right here, but they would be able to see everything in the periphery. And if you look at the picture on top of the house, that's what this patient sees. Big blind spot right in the center. And for those of you that have this, I don't need to go into any more detail. This is pretty serious business. But for those of you that don't, imagine seeing the world like this. You look at your grandkids and you can't actually see their face. You can see their ears and their hair. If you're looking right in the center of their face, but you can't actually see the details of their face, and that's pretty difficult. You have trouble watching television, trouble reading, and it's really quite debilitating. So this is a very, very serious condition. Right now there's no treatment for it, and investigators around the world, with the help of Foundation Fighting Blindness and other organizations, are really working hard to find a cure for this. So this is the same picture, but it also shows the OCT scan. Now the OCT scan, as many of you are familiar with, is this little cross-section of the retina down here. It's a slice through the center of the retina. And these lines are the layers of cells, which are pretty normal over here. But in the center, you're missing a bunch of cells in the middle. And that's why the light gets imaged behind it, but you see this big beam of light passing through the retina, because the pigmented cells, which normally absorb the light, are not there. So this is a very abnormal OCT scan with a whole section, like a cookie cutter, a whole section in the middle that's missing important cells. So the goal of the stem cell surgery is to put those cells back. Now there are lots of challenges, which I'll talk about. Another test you may be familiar with is called autofluorescence, and everywhere it's dark is an area where the retinal pigment epithelium is either absent or not functioning or dead. You see the blind spot in the middle of dark, which corresponds exactly to the visual field defect that I showed. Here's a higher magnification, and all this dark area in the middle corresponds to this area here, where the cells are missing or dead. So anything dark on this is bad. But what's interesting is it's a little hard to see in this picture, but right around the dark, there's a little rim that's actually a little bit lighter. And that shows cells that are very damaged and are about to die. So patients with this problem, they have a blind spot, and slowly that blind spot expands. So one of the goals of the stem cell therapy is not only to try to replace what's missing in the blind spot, but try to prevent the damaged area from dying. We can reverse that damage and turn that damaged area into a healthy area, then the patient wouldn't have any progression of disease, and they might even have some reversal of their disease. So you've seen this already, the structure of the retina. This is a magnified view of the retina. You see on the extreme left the RPE, that's the retinal pigment epithelium, the really important cells. Right next to it you see the photoreceptors, and those are the rods and cones. That's another word for rods and cones, is photoreceptors. Most people have heard of rods and cones. And some other cells that are important in the retina. Now this eye, this diagram is looking to the right. So if we now turn the eye so that it's looking up, we see the retinal layers here, and that's what corresponds to the OCT scan. These lines on the scan are basically these layers of cells. The cell nuclei are dense and they form different patterns in the retina, and then when you expand it to the big OCT scan, that's what we're looking at there. All these lines are different layers of cells all lined up like a layer cake. And this little divot or depression in the middle is pretty normal. That's the way you want the center of the retina to look like. But in this case, you see all the lines are intact. Everything looks pretty normal. You follow each of these lines, which is a different cell that goes all the way across, and it's still there, which is good. So the retinal pigment epithelium, which is the layer behind the rods and cones, it's really a critical layer of cells. They provide the nutrition and basically the life support for the photoreceptors or rods and cones, and they do a whole bunch of other things, which you see listed on the right. Alex mentioned that it's involved in vitamin A metabolism, which is true, and it does many other things. Most importantly, it takes away waste products. So the rods and cones are very active, as you can imagine. Those cells, in order to process vision, when light is present, those cells are working really hard. They require a lot of oxygen from your bloodstream. They require a lot of nutrients from your bloodstream. And their cells, they're revved up all day long when your eyes are open and you're looking at things. They're resting at night, but during the day they are really cooking. And they produce a lot of waste, as you can imagine, since the cells have a really high metabolic rate. And those wastes need to be removed. That's what the retinal pigment epithelium does. The retinal pigment epithelium is sort of like your liver. If you have toxins in your bloodstream, the liver clears them out, and the kidneys remove them as well. But the cells in your liver are really important to get rid of bad substances in your blood. The RPE in the retina sort of has an analogous function in that it gets rid of the waste from the retina. So you can imagine if the retinal pigment epithelium isn't working well, all these waste products build up in the retina. And that's what we think drusen are, those little yellow deposits, sort of an accumulation of things that shouldn't be there, an accumulation of things that should have been removed. So we have two diseases where the RPE doesn't work well, many of those diseases, but I'm only going to talk about two. One is the macular degeneration, obviously, AMD. The other was called Stargardt's disease. We abbreviated SMD here, Stargardt's macular dystrophy. I'll talk a little more about that later, but that's a disease that affects young people, usually 8, 9, 10 years old. They start noticing central visual loss, and by the time they're 15, 16 years old, they have a retina that actually looks like a macular degeneration retina, and they're permanently legally blind for the rest of their life. So these two conditions are very similar in that the retinal pigment epithelium is dead or absent, and they're both amenable to stem cell therapy. So again, if we can replace those missing retinal pigment epithelial cells, that would be quite amazing, because this is such a serious disease, macular degeneration. And Stargardt's, even though it's extremely rare, it's also a very serious disease. So there are some nice things about this. If you can solve this problem, not only those two diseases, but there's actually a couple hundred other diseases that the RPE plays a role. Hard to believe, but some very rare diseases. And we call this unmet medical need. There's conditions that there's no cure. What's nice about the eye is the unique observational environment, which means you can do something to the retina, and then you can actually look in, take a picture, image it with some of the sophisticated devices that you heard about, and actually see what's going on. That's the beauty of retina, is when you do surgery on it, you can then look at the retina the next day and see how the surgery went. A heart surgeon can't look at the heart and see how he did, but the retina surgeon can, and it's nice because you can see how the patient's healing and how they're doing. If we use stem cells, it's a small dosage, which is good. The company is able to then make the cells. The eye, as you heard Tim mention, is an immune-privileged site, which means it's somewhat protected from the immune system. So for example, if you get a kidney transplant, you need to take medicines to suppress your immune system for the rest of your life. And some of those medicines are pretty potent, and some of them cause some problems. Patients get infections. Patients actually can even get other cancers from these immune drugs. When you do the stem cell surgery, the eye is not really exposed to the immune system as much. So we give some immunosuppression, some drugs that suppress the immune system, but we only do it for a number of weeks. And you don't have to worry about all the bad side effects of these immune drugs like you do in patients with kidney transplants. So there are some nice things about the eye that enable it to get this type of therapy. So the company that does this is Advanced Cell Technology. The field of stem cells is called regenerative medicine, in case you've heard that term. And this little picture here shows some green human stem cells sitting on a bed of mouse fibroblasts, which are types of cells that just help the stem cells grow. It's a nice picture that the company supplies. So it's hard to believe that stem cells were only discovered about 15 years ago. And we've come a long way. On the right, you see a diagram which shows that a stem cell, which is an immature cell, can be turned into any kind of cell in the body. It can turn into a nerve cell, it can turn into a cardiac cell, it can turn into a red blood cell, and what we're showing, it can turn into a retinal pigment epithelial cell. Now, I think that's pretty amazing. I think it's amazing that a fetus has cells that are undifferentiated, which means they're general cells, and those cells divide and eventually become every cell in your body. Somehow those simple cells know how to become very specific. And some cells become retinal pigment epithelial cells, some cells become heart cells, some become neurons. I mean, it's amazing that the human is able to do that. And those pathways are very not well understood, let's put it that way. It's truly amazing that this happens. But when you have a stem cell, the company that does this can actually direct those stem cells to become specific cells, which is quite impressive. Really some amazing scientists working on this. So here's Advanced Cell Technology. They actually are a publicly traded company on the stock exchange, and they're located in Santa Monica, California, as well as Marlborough, Massachusetts. And they're engaged in the only human embryonic stem cell study in the world. So this is the most important slide of the whole presentation here. Embryos are not destroyed to make this line of stem cells. Everybody always asks this ethical question, and it's very, very important. When I did the stem cell surgery in our operating room, we actually had several nurses that didn't want to participate because they heard it was stem cells, and for ethical reasons, they didn't want to get involved. And that's okay, but it is important to know that embryos are not destroyed for this. This is a cell line that was created in 2005, and they take one cell out of this cell line, and they reproduce this cell forever. They will never need to do anything else in the future to create another cell line. The cell line has been created, did not destroy anything, and now they take those cells and they turn them into other cells in the body. So this can be challenging for a variety of reasons. I made it sound pretty simple so far. You just replace some dead and dying cells and the game's over. But think about it. You have to have these cell lines be completely free of bacteria, fungi, viruses, and it's very common for these cultures in the laboratory to get contaminated. So they're constantly checking the cells to make sure there's no sign of infection. In fact, when they deliver the cells to us in the operating room, the laboratory that the company is located is about 45 minutes away from my operating room. So they take the cells out of the freezer and they put it in a car and they call us and they say, okay, we're on our way. The cells have to be implanted within a specific amount of time. So we have the patient waiting in the operating room. We can't start the surgery until the cells actually arrive. But while the courier is driving the cells to our operating room, there are about 20 people at the company in the lab testing the actual sample that they sent us is testing for bacteria, fungi, viruses. And it takes them a while to do the test, and I can't actually start the surgery until I get a phone call from the laboratory person telling me that, okay, the sample we gave you is free of infection. So the last thing we want to do is implant some cells and find out we caused a serious infection. So this is really, really challenging. And they test this over and over and over again to be sure that the sample we get is pure and clean. So they also have to worry that we want these cells to grow. Okay? Once we implant them, we only implant a certain number of cells, not enough. We want those cells to multiply. But as you well know, if cells multiply too much, they cause tumors. Right? We don't want the stem cells to grow uncontrolled and have a stem cell tumor. Or we don't want them to metastasize and find out, 2 years later that you've got a retinal pigment epithelial cell that's supposed to be in your eye and it's, in your pancreas or something. So there are a lot of challenges here, and it's pretty complicated stuff. You also want the cells to be slightly immature, so you don't want mature retinal pigment epithelial cells because they don't take as well as immature ones. And that's pretty difficult. The scientists at the company have to get all this right. I don't have anything to do with any of this. I just do the surgery. But they have some really important roles, and they've got some brilliant scientists working there. So before these things are implanted in humans, obviously, they do experiments in animals. And there are certain diseases in mice and rats that are similar to human diseases, where the retinal pigment epithelium does not work, and as a result, the rods and cones die, and the mice and rats go blind. Well, they implanted the stem cells in these mice and rats, and actually the human pigment epithelial cell, as you see here, landed in the right place. This is a mouse retina. Here's the mouse pigment epithelium, the mouse rods and cones, and so forth, and the human retinal pigment epithelial cell ended up exactly where it was supposed to, and it actually started helping the mice and rats. In fact, on the left is what the animal's retina looked like before, and the rods and cones are basically missing, so the animal's blind. But on the right, after they were given stem cells, the rods and cones started growing back, looking pretty good. And in fact, some of these animals got some vision. So this was pretty good news. Clearly, you can't always extrapolate what happens in an animal to a human, but this is, was pretty encouraging when it was first studied. So now we'll talk about the humans. This is a phase 1 study that we've done, and as I mentioned, there's been less than 20 patients around the world that have had stem cells. There's 12 patients planning on getting this for macular degeneration in the US, and there are some patients getting it for Stargardt's macular dystrophy. Here's a picture of Stargardt's. As you see, it's very similar to the macular degeneration photo that I mentioned. So for the macular degeneration patients, the first 3 get 50,000 cells implanted, the second 3 get 100,000 cells, and that's where we are now. And if those are safe, then we progress to 150,000 and so forth. And we watch these patients very closely to make sure they don't have any of these problems that I mentioned. And this is done at a variety of places in the US, Los Angeles, Philadelphia, Boston, Miami, and 2 places in the UK. So to enroll in this, since many of you have macular degeneration, very, very few patients actually qualify for these studies. And we don't always make the rules. The FDA sets these guidelines because they want to make sure we choose the appropriate patient and that we don't cause any harm. So you have to have severe vision loss in one eye, but you actually have to have pretty good vision in your other eye. And the reason is, anytime we do a study, this is an experimental study, we all know that the possibility is there that we can actually make the patient worse, right? We can do this surgery, and not only might the surgery not work, but something can go wrong. The patient can get a retinal detachment or whatever. We don't think that's going to happen. So far it hasn't. But anytime a study is undertaken in medicine, that's always a possibility. So we always want to choose patients where their other eye is good, so that we're operating on their eye that they're not really using. It's sort of a spare tire. And if something happens to that eye, it's not the end of the world because their other eye is they're using for everyday life. So that's really important. They have to have no other eye diseases. They can't actually have glaucoma, diabetic retinopathy, nothing else. They can't have any history of cancer, nothing, because as I mentioned, stem cells, maybe, who knows, maybe can cause a tumor somewhere. We don't think so. It hasn't happened, but theoretically it could. So if a patient had a history of cancer and then the cancer comes back, we won't know if it was caused by the stem cells or just by their cancer coming back. So patients can't have any cancer. In fact, we have to screen them. They have to get colonoscopy, mammograms, prostate tests, et cetera, to make sure that they're pretty healthy. And they also have to be able to handle a little bit of immune suppression, those medicines I mentioned, for a few weeks. But most important, they have to be psychologically suitable. And that sounds silly, but it's actually extremely important. The patient needs to be pretty intelligent. They have to understand everything we've talked about. They have to undergo a lot of testing. And they have to be really willing to take a risk. And I think these patients are pioneers, because the patients who enroll in this study, there's a small possibility they're going to get some improvement. Not a huge possibility, but a small, because this is the early stage. This is the very, very beginning of stem cell studies. And, they got to have some guts. They really are getting this procedure done, in effect, to help future people. It may help them, which would be nice, but I think they're really performing a service to society more so than they're performing a service to themselves. So I give a lot of credit to patients who enroll in these studies. And I've always thought about what I would do if I was ever asked to enroll in a study, but I think I'd probably go for it, because I think it's really good for society. So, as I mentioned, patients get a few medicines to suppress the immune system. This is only temporary, luckily, one drug for 6 weeks and one for 12 weeks. This is nothing like what you get for a kidney transplant, when you have to be on these nasty drugs forever. And this is such a short period of time that these drugs really shouldn't cause any problems at all. So here's the guy in the lab preparing the cells before they deliver them to us. The cells are very, very delicate, so you have to carry them very carefully. You can't shake them up. As I mentioned, you only have a few hours to implant them from the time they leave the lab. They've got to be at a perfect temperature, and preferably within 2 hours of leaving the lab, although we can do it up to 4 hours. They deliver these little tubes to the operating room. We have to mix them in a special way, being very careful not to damage the cells. And then we have to inject the right amount of cells. So it's really pretty technically challenging. Now, regarding the surgery, it's called a vitrectomy. Has anybody here had a vitrectomy? Only one, okay. Well, vitrectomy is what retinal surgeons do all the time. We fix retinal detachments with vitrectomy. We fix diabetic retinopathy with vitrectomy, lots of things, trauma. And vitrectomy is where you remove the vitreous. That's the gel that fills the back of the eye. And if you're going to implant some cells underneath the retina, you have to take out the vitreous first. And that's what we do. We'll show a video of this in a little while. And you have to prepare where you're going to inject the cells. You want the cells to land on some normal retina, some abnormal retina, and some retina that has absent pigment epithelium. And you have to inject very, very small amount of fluid. So here's sort of a diagram. The vitreous fills this big cavity here, okay? So we take out the vitreous with a little device that sucks and cuts, which I'll show you. And then we put this tiny little cannula through the eye, and it pierces the retina and blows up a little blister of fluid. As you can imagine, this is pretty small stuff back there. It's pretty delicate. And to explain the surgery a little bit, I'm holding a syringe that's very small, and the tip is just under the retina. And obviously, if you go too deep, that's a big problem, and if you're not deep enough, that's a big problem. But what's even more complicated is my assistant has to push the little plunger of the syringe, and he's got to push a tiny, tiny, tiny amount of fluid. And it's really difficult. We practiced probably 50 times, so that when we did it for real, he would inject carefully and not inject too much or too little. And also, he doesn't want to put a force on my hand, because obviously I have to hold very still. It's not easy to hold something still when somebody's pushing a plunger down. In many studies, you have some extension tubing that's attached to a plunger, but we can't do that in this study because the cells are so delicate. So he's actually pushing the plunger that I'm holding. So this shows what it looks like in the operating room. We'll show a video again in a second, but this shows the surgeon's view. Got an instrument in each hand. One of them has a light, and that's what you see illuminated over here. This is the light instrument. It's a little fiber optic light that aims like a flashlight. And here's the instrument that I just showed in the picture that goes under the retina and blows up the little blister. So we have to select the site ahead of time. We do an angiogram to see the degree of atrophy, which you see here. Then the little yellow circle is where we plan on injecting. And then we plan on blowing up a blister the size you see here, where some of it involves the dead retinal pigment epithelium, some of it involves the abnormal, and most of it involves the normal. Now here's the video. If you don't like blood and guts, please don't look. This is how we enter the eye. Really, this could be a little gross for some people, so close your eyes if you don't like this. We make a hole, we put a little IV tubing in there to fill the eye with fluid, because as I said, we're going to suck out the remaining fluid. We make another little hole. Hard to believe, huh? And finally a third hole, because we have two hands, and we put instruments in one of these two holes, and with the IV filling the eye with fluid. Now we have a lens over the eye, and we look in, and this patient had some opacities in their vitreous. This is the vitreous that you see, you'll see in a second. It'll be shaking back and forth. Here's the instrument over here that's sucking and cutting the vitreous. And when it's moving back and forth, that means some of the vitreous is going in this tube and being sucked out. After we remove all of the vitreous, we then put a different lens on the eye to focus high magnification. And we blow up a little blister. Here's the instrument back here. That's the assistant is pushing the plunger, and we're blowing up a little blister. That's just of saline. There's a little bubble on the retina that we try to get rid of. And then we put another instrument in containing the stem cells. We try to find the same hole that we just created to get into the blister and start injecting into the blister. You can see the big area of atrophy here. So then soon you'll see a little blister. You can probably see it right here. It's going to get bigger and bigger. You see the blister. So I'm holding this while he's injecting. The blister is getting bigger, and the stem cells are going under the retina, blowing up a little area of fluid. And eventually it gets to the proper size. You can see it slowly getting bigger. There's a little microscopic hole here that we've got this thing in. You can see it's nice and big now. And that's basically it. So, as I mentioned, there was the site that we wanted to inject. And you see on day one, the little hole we made is barely detectable. You see a tiny dot there, but that's it. And all the fluid that we injected under the retina, there was a huge blister here. It's all gone by the first day, which is what we want. The body sort of absorbs the fluid, and hopefully the cells are just sitting under there. And here's another example of what it looks like day one. You see the little tiny defect in the retina that's now already healed. You don't even see a hole, you just see a little remnant. It's pretty good for the first day. And here you see 1 month out, everything looks nice, it's the way it should. Now we'll show you some results for some other patients, because they have a little more follow-up than in my patient. Here's a patient with Stargardt's, and baseline over here on the left, that's before surgery. You see no pigmentation here. And here's week 1, you already see some pigmentation. So the cells that are injected aren't pigmented, but they start to pigment as they start to mature. So this is good. This means the cells are in the right place and they're actually taking. And here's the same patient at week 6. There's even more pigmentation under the retina. This is pretty good. Very encouraging. So here's again at baseline before surgery. You see this little white line there. That's normal. All the remaining retina is missing the white. The white is the pigment. And look how big this little white area is. That's before the surgery. And now after, it's like about 3 or 4 times the size. That's good. Those are cells that have now found their home. And they've located themselves in the right place. It's just what we want. So here's another patient with Stargardt's. This shows the injection site where the arrow is, and the dotted line shows the blister that was created. And here's the patient at 1 month after surgery. You see some new pigmented cells. And 2 months after surgery, you see more pigmented cells. That's exactly what you want. So far so good. The cells are finding the right place, and they're growing. Here's another patient, same thing. And once again, at 1 month and 3 months, you've got pigmented cells all over the place, which is good. So the results in terms of vision, I don't put too much into this because it's still very early to conclude anything about the visual results. But actually, in both the Stargardt's macular dystrophy patients and the dry AMD patients, vision has actually started to improve. Now remember, some of this could be placebo effect. When patients are in clinical trials, they're trying really hard. So when they look at the eye chart, all of you probably know, when you look at that eye chart, it's dependent on how much effort you give it. You blink a few times, you move your head, you move your eye, and you can sometimes be coached and get a few extra letters. So these patients did have improvement, but again, some of it may just be bad. That's why we always have placebos in medicine, because some of this can be just the placebo effect. We have to have control groups. So it is encouraging that the patients have some improvement in vision, but I don't put anything into that just yet. So out of the 6 patients so far, the AMD study, we've had no problems, and that's really what this study was designed to do, to make sure that there's no complications. And the same thing with the Stargardt's. Really, there's been no complications in any of these patients so far, despite all the horrific things I talked about earlier that we're worried about. So this was published, 4-month data in the 2 patients, one with macular degeneration, one with Stargardt's, and there was no signs of inflammation, no signs of abnormal growth or tumors, no signs of rejection, no signs of retinal detachments. This is really nice. And the cells engrafted where they were supposed to, and they survived, and they reproduced, and they made pigment. So these are all really good things. And again, regarding vision, maybe some improvement, maybe not. Way too early to conclude anything. But what we don't know is the long-term effects. Okay, we've only been doing this for a few months, and we don't really know the ultimate effect on visual acuity. So there's a lot we don't know. So to finish, we will continue to enroll and treat patients in this study. We'll assess the safety data, we'll assess the efficacy data, see how they're doing. And if things look good, which they are so far, we'll continue. And we're probably going to treat it at an earlier stage. The FDA has just approved us to start including patients with a little bit better vision than what I described earlier. Initially, you had to be worse than 2400 and had to have a massive area of atrophy in your retina. And for the next group of patients, you could be, I think, 2080, which is a bit better, and not have such a large area of atrophy. Personally, I prefer not to enroll patients who are doing that well. I'd like to stick to the patients with very, very severe disease, because I think we don't know enough about this yet. But this is encouraging and a long way to go. But I hope I've separated some of the hype from the reality and you have a better understanding of stem cells. Thanks.
So we're going to take a little bit of a break. We're going to come back.